to high-quality genetic counselling services, regardless of their geographic location or socioeconomic status. So I'm not going to share our mission statement. One can read that at a later stage, or the objectives, as I'm very aware of time. But just to mention, we're very much aware about the challenges in Africa and the difference between genetic counselling and genetic counselling services, and how we're going to try and bridge that gap to try and reach more individuals in Africa. So where we are in that we have been registered as a non-for-profit organisation or business, and our board invitations are being finalised and sent out. Our webpage and membership details will be coming soon, but we will be having our first official meeting at the 15th African Society of Human Genetics Conference, which is being based in Uganda from the 3rd to the 7th of Feb. So I'm hoping that many of you will be there, and that we get to start the ball rolling and to try and increase the genetic counselling landscape in Africa. Thanks.
Thank you. Thank you very much. I will introduce our moderator, Mohammed. Mohammed, can you?
Yes.
Okay, thank you. Thank you.
Shall I take over? All right, perfect.
Yes, yes.
So good morning, good afternoon, good evening, depending on where you're joining from. Welcome to this inaugural webinar that's been organized by the EU Africa PerMed, as well as the Africa Genetic Counseling Association. My name is Dr. Mohammed Zahir. I am a molecular geneticist and genetic counselor based in Dar es Salaam, Tanzania, at the Department of Biochemistry and Molecular Biology, Muhimbili University of Health and Allied Sciences. So in this inaugural webinar, we will be dissecting the topic of genetic counseling in Africa and Europe, where we will be discussing challenges, innovations, and perhaps future directions as far as this field is concerned. The webinar primarily aims to explore the unique obstacles and breakthroughs in genetic counseling across two diverse continents. We will therefore try to delve into the varying genetic health issues, resource availability, and of course, cultural perceptions that shape genetic counseling practices in Africa and Europe. Our expert speakers will share insights into the latest innovations in the field and discuss how these advancements are shaping the future of genetic healthcare in these two continents, and what can be done to bridge the gap and foster positive collaboration in the field of genetic counseling continentally, but also globally. So as the program is going to be directed, I am honored and it's my pleasure to serve as the moderator for today. We will have 3 fantastic talks to start with. Each of them will be roughly 20 minutes long. And thereafter, we will have a roundtable discussion where all the speakers and more will be invited to participate on some of the discussions on the topic. So without really wasting any further time, I want to take this opportunity to invite our first speaker, and I want to briefly introduce her. So the first speaker is Kelly Ormond. She is a health ethics and works at the Health Ethics and Policy Lab at the Department of Health Sciences and Technology in Zurich, and the Department of Genetics at Stanford School of Medicine in California. So Kelly is a genetic counselor and LC researcher. She received her master's in genetic counseling from Northwestern University and a postgraduate certificate in clinical medical ethics from the McLean Center at the University of Chicago. She then joined the Health Ethics and Policy Lab as a senior scientist in February 2021, and is also the adjunct professor at the Department of Genetics at Stanford School of Medicine in California, USA. Of course, Kelly is a fantastic researcher with a lot of experience, over 25 years under her belt. She's had, great experience also with education, particularly for master's level genetic counseling at the Northwestern University and Stanford University. And of course, she served on the Hospital Ethics Committee at Stanford. And throughout her career, she has served on different committees and boards for many U.S. national genetics organizations and currently serves on the ESHG Program Committee. She's also the current president of the Translational Alliance for Genetic Counseling. And Kelly's recent research focuses on ethical issues related to genetics and personalized medicine, including patient decision-making, the role of uncertainty in decision-making, consent, and disclosure of genetic test results. And today, of course, she will be talking about the overview of genetic counseling around the world. So without any further delay, Kelly, over to you, and you may proceed. You have 20 minutes. Thank you.
Great. Thank you. Can you hear me okay?
Yes, we can hear you perfectly.
And you can see the slides?
Yes, positive.
Right. Amazing. Thank you for such a kind introduction and for having me talk about one of the things that I'm really very passionate about, which is genetic counselors and genetic counseling around the globe. And I would say that despite all of the many things that you heard about from my background, I think the main reason I'm doing this talk is because I am the current president of the TAGC. And so what I'm going to try to do, and I will try very hard to keep it to 15 minutes so we have more time for our panel discussion, is to talk a little bit about how genetic counseling has been evolving around the globe and set the stage for our two speakers who will be talking about the perspective from Africa and Europe. So, of course, as a genetic counselor who trained in the United States, I really have experienced a lot of significant growth of genetic counseling. And there's a really lovely paper by Bonnie Beatty a few years ago that described the trajectory of genetic counseling as it began to develop from the late 1960s in the United States. And now the United States have almost 7,000 genetic counselors, believe it or not. So the numbers have increased quite a lot from the 40th anniversary that I had on this slide. And it's really been quite phenomenal growth. But one of the things that I also want to emphasize, and maybe will come up in the panel, is that because the US has had such a long history of genetic counseling and genetic counselors, they make up, between the US and the UK, it makes up quite a lot of the papers that exist. So I want to stress that while that gives great ideas for how Europe and Africa might think about developing the profession, it also has a lot of places where it's just not going to translate quite properly because there are so many differences. So I came to a lot of this international work by being a part of the TAGC, which was initiated by Janice Edwards about 15 or so years ago, almost 20 years ago now. And it was meant to really focus on getting people who were doing genetic counseling educating together from around the globe to just talk about what we were doing and be a resource to each other. And I would say it's evolved quite a lot from there. But that group really led to this very first paper that we have, which is published about 5 years ago now, and was our first pass at looking at how genetic counselors and genetic counseling looked globally. And they were these two papers. And since that time, there have just been a ton of papers about what's been going on in genetic counseling around the globe. This is certainly not all of them, but you can see that there are papers that are coming out of different parts of Europe, papers coming out of Asia, papers coming out of Africa, all over the place. And so this prompted us to work on a paper which was just published online a few weeks ago called The Global Status of Genetic Counselors in 2023, What Has Changed in the Past 5 Years. And this is available on open access. So you can look this up. And if you can't get a hold of it, you're welcome to send me an email and I'm happy to send you a copy. The proof version is out now and the other versions probably will be out later this week. But you can see from these images where the bulk of genetic counselors are located around the globe. And we're still seeing that most of them are located in North America, between the United States and Canada. You can also see that within Europe, we have quite a lot of genetic counselors, nearly 1,000, spread out across much of Western Europe, but not nearly as much of Eastern Europe. And then you can see in Asia, and you can look down here in the bottom, that there are many countries in the Middle East and Asia that now have a population of genetic counselors. China says 6,000 here, but this one is a bit complicated because, and this will get into how we define what genetic counselors are around the world. Those are individuals who took a very short genetic counseling course that's about a 1 or 2 week equivalent. So that's very different than the training of most of the other genetic counselors that we're documenting around the world. So we also are aware of about 136 genetic counseling training programs that exist across 30 countries. And you can see here on the left-hand side of your screen, these are countries that have more than one genetic counseling training program, and then countries that have a single training program. Most of these are master's level programs. Some of them are postgraduate diplomas or certificates in a handful of countries. And over time, those do seem like they turn into master's programs, but I think that remains an open question that might be worth discussing, which is what is the best way to educate people to provide these genetic counseling services across the globe and particularly across Africa. When we looked at all the data that we got on this last paper, there were 3 key areas that I just want to point out as a bit of a teaser in terms of how we're thinking about these global questions. And the first one is, how do we define who is a genetic counselor? So again, you've heard that the service of genetic counseling can be performed by many different types of healthcare providers, certainly medical geneticists, many other doctors do genetic counseling as a part of their own scope of practice, and then genetic counselors have the particular scope of practice and training to provide genetic counseling. Most genetic counselors across the globe, as I said, are master's level trained, but there are healthcare professionals in other areas, maybe nurses or physician assistants or other medical providers, who will undertake a certificate or a diploma to be able to then conduct genetic counseling in their own practice. And so this raises the question, it came up in our paper, and I think it will come up in other places. How do we think about 3 really key aspects of how we're defining a genetic counselor? Part of this is title protection, so that we know who a genetic counselor really is, and your next door neighbor can't just call themselves a genetic counselor. Part of this is to prevent harm to the people that we're serving. We don't want your next door neighbor to say they're a genetic counselor and then give your patient bad information and then have them make a medical decision that's not appropriate and have harm occur as a result of this. And then I think the other issue that comes up in how we're defining genetic counselors relates to the regulations that exist and also to our ability to bill for the medical services that genetic counselors provide, which of course will provide the foundation in many cases to how you can pay for the time of the professional that you're hiring. So the next question that came up was, who do genetic counselors work with? Are they only working with medical geneticists, for example, or are they working with other medical specialists? So for example, an oncologist, a cardiologist, an obstetrician, in more of a sort of mainstreaming approach where we bring genetics to the various specialties. And many genetic counselors work outside of a clinical setting. They might work in a laboratory, helping to sometimes even do variant interpretation, sometimes write reports, sometimes make educational materials, both for the medical providers and for the patients who are considering the testing. They might work in public health settings, and they might work in a research setting, such as H3 Africa, for example. And across all of these settings, genetic counselors play different roles. Again, they may have clinical roles, they may have research roles, they may have teaching roles, and we don't know very much about these different roles that genetic counselors play. So I want to tell you about one other study that I did with some of my colleagues about a year ago, where we were really trying to get at this question: what do genetic counselors actually do? And so this is another paper that I did with John Weil and actually Tina Wessels, who's on the call, I believe, today, where we surveyed many genetic counselors around the globe, and we had about 190 individuals complete this survey. As we were looking at what countries people came from, you can see that there were 7 countries where we had at least 10 respondents. So Australia, Canada, the United States, the UK, France, Japan, and India. And then the other, I think 33 or so were from countries where we only had 1 to 4 respondents, so much smaller numbers. And what we did was we looked first at the demographics of who were these individuals, as well as what kind of time were they spending in their different clinical services. You can see that 90% of our respondents did have a master's degree in genetic counseling and had been in practice for a little more than 7 years. And about 77% did at least some percentage of their work in a public sector. So we asked these individuals, in a sort of quote unquote typical case that you might see in your practice, which of the following components or categories are things that you do on a regular basis? And this table here shows you the most highly endorsed tasks that people did when they were genetic counselors. So you can see that as far as case preparation, they were reviewing patient and family medical records and confirming the eligibility towards genetic testing, either clinically or through a research study. When they were beginning the session, they were establishing rapport. They were determining through the family history which diagnoses might need more confirmation, analyzing the pedigrees that they were taking, identifying which family members were at risk, integrating together all of this information, the medical, the laboratory, the genetic information, and then providing counseling to patients around their genetic risks. A lot of this also fell into education, both about the diagnosis and the natural history that was being considered, as well as about the testing options, and ultimately about the test results. So you can see, actually, I don't know, probably like 10 or so different categories were falling into that. And then assessing patients psychosocially, so recognizing the patient's factors that might impact a counseling interaction. Of all of these, the most consistently endorsed role was this review of records piece. And the roles that had very few endorsements were things that overlapped more with a medical role. So they were less taking the medical history, you know, a full review of all of the body components, for example, or doing a physical exam. And surprisingly, we also saw less endorsement for providing psychosocial support. And it's hard for us to really know exactly why that was. This slide, and I know it's much harder to see, so I would refer you to the paper if you're deeply interested in this, but we looked at where we saw the biggest differences between countries, and we actually saw that one of the places where we saw the biggest differences was under providing psychosocial support, as I just said. And so I'll give you a close-up here of what this might have looked like. So we had, I think, 9 different tasks or categories of roles that a genetic counselor might do under the umbrella of providing psychosocial support. And you can see here that in some columns, we would have 95 to 100% endorsement by some countries. So let's say addressing client emotions or behavior. And then in some countries, we would see much lower responses. So the ones in yellow were where we saw more disparate responses. I would say that the countries that have had genetic counseling much longer, Australia, Canada, the US, and the UK, did tend to be a bit closer to each other, particularly in these categories. And we saw a little bit more spread when we compared those then to France, Japan, and India. So why do we see similarities and differences across the world? Well, I think part of it is that we're seeing these shared similarities because we have a scientific basis for the service of genetic counseling. And there are some baseline psychosocial needs of individuals and families that are going to cross country boundaries and cultural boundaries. There's also been quite a lot of international exchange, both scientifically and on the education side around this. But I think a lot of the differences are just due to the differences that we have between countries, around our healthcare systems, around the way our government regulates things, around the way that things like insurance and medical payments are managed, and around the values and expectations of the populations that are served. So this, I think, will be a lot of fodder for our discussion on the panel. TAGC is a resource that I would certainly encourage you all to look into. We have actually removed all of the fees for membership at this point. I forgot to go on the website earlier today to make sure that that had been updated, but if it hasn't been, you can send me your email if you'd like to join. And we have a listserv of about 250 individuals around the globe that actively talk about lots of different things. And in fact, we will be also having a meeting probably either before or after the World Congress of Genetic Counseling in February of 2025, so in about 6 months or so, where we might talk about some of these things. And so with that, I'll show you some lovely pictures of where I used to work at Stanford University, and this image of the genetic counselors who worked there about 5 years ago. And you can see there are about 50 of them just at this one medical institution, which is more than are in all of Africa put together at this point. So I put this out there just to really, again, reinforce the stark differences that we're seeing across the globe. And then I'll end on this slide just showing you some of the students that I've had the pleasure of interacting with at the program in Innsbruck, Austria, and also the program in Siena, Italy. So I am doing a little bit of teaching with those programs as well. And so I have written up my email here if people would like to contact me, and I will end there. I don't know, Mohammed, if you want to take specific questions now or just hold everything for the panel so we can keep rolling.
Yes, thank you so much. That was a fantastic presentation and a great overview of what's the status of genetic counseling from a global perspective. I think we'll probably proceed with the next speaker, and then we'll get all questions together once all the speakers are done, so that it is a continuity after the panel discussion. I hope that's okay. So I quickly want to introduce our next speaker, who will be talking about the African overview of genetic counseling, and that's none other than Kalinka Popel. So in brief, Kalinka is an HPCSA and GPC registered genetic counselor. She obtained her master's in genetic counseling in 2017 at UCT, and therefore she has assisted with project coordination on a project for hereditary hearing loss in Africa for the last 6 years. She has also assisted some aspects of teaching the genetic counseling course and courses at UCT. Since 2022, she has been appointed as the genetic counselor at the West African Genetic Medicine Center at the University of Ghana, where she is tasked to provide the practical training and lecturing on the first genetic counseling degree in West Africa. So together with colleagues, she's starting, of course, the AGCA with the aim to create awareness, expand research, and provide teaching and create collaborations across Africa. So without any further delay, we welcome you, Kalinka, to start your presentation. And just like the first speaker, you have 20 minutes. Over to you.
Thank you, Mohammed. Just before I take over, my colleague, Nakita, she is going to start off the presentation just to give an overview from genetic counseling in Africa, and particularly also South Africa, then I will take over from her.
Fantastic. So before I allow you to do that, let me quickly introduce Nakita as well. So Nakita is an HPCSA registered genetic counselor working in both the private and public sector in South Africa. She also obtained her master's in genetic counseling at the University of Cape Town in 2011 and has been working with the Division of Human Genetics since then. She also assists with the teaching and training of undergraduate MB-CHB trainees, as well as postgraduate MSc in genetic counseling courses, as well as supervises both trainees and interns on the clinical platform. She is also a co-investigator on a cardiomyopathy research group, as well as cystic fibrosis research projects. She's also the previous outgoing chair of the Genetic Counselors South Africa Association, and therefore, and together with colleagues, is starting with the AGCA for the creation of awareness, teaching, training, research in the space of genetic counseling. So with that, Nakita, you can start, and then Kalinka will follow. Most welcome.
Thank you so much, Mohammed, for the kind introduction. I'm just checking that I'm audible.
Perfectly
Okay.
audible.
Wonderful. So, I mean, I don't really need to go into this, as Kelly has spoken about this a little bit. But that picture that Kelly posted about having 50 genetic counselors in one institution was quite a scary thought, to think that we have less than that within Africa. So I just wanted to highlight the population sizes of both Africa and South Africa. You can see that in Africa, we comprise 18.3% of the total world population, and South Africa having 63 million individuals. And Africa, I mean, I don't even know how to say that large number, but I think it's 1,520 million individuals across Africa. And because of that, not because of that, but rather to say that despite that vast number of people, we only have 2 places where genetic counselling is formally being offered. That being said, if you look across Africa, and I've spent quite a lot of time actually looking at trawling Google Scholar, looking at African genetic counselling research papers, and there's quite a number of projects and a lot of research happening across Africa. A lot has to do with premarital counselling and screening, but there has been some other programs that have started in Ethiopia and Kenya, looking at some training courses and some lovely collaborations that I've seen crossing borders. In South Africa, we have 2 training institutions, being Cape Town and Gauteng. And there are clinical services available in Northern Gauteng, Pretoria, as well as one city in KwaZulu-Natal. But you can see the fact that the majority of Africa and South Africa does not have access to genetic counselling services. So just a brief overview about South Africa, seeing as that's where I'm coming from, and to state that we've got about 33 genetic counsellors practicing in South Africa in both the public and private sector. We've got a further 17 that are registered, but unfortunately have not been able to secure work in South Africa. So they are working overseas or are being employed in other sectors. And luckily, we've got another 6 graduates busy with their internships, which we hope to see qualify in a couple of months' time. Those 33 practicing genetic counsellors are majority actually practicing in the private sector or in laboratories, with very few in the state sector, and some working in research groups, which is starting to increase. And then in Ghana, our only other master's training program that Kalinka is a lecturer on, there are 4 individuals who have graduated but are still busy completing their internship. So a bit of a brief history of genetic counselling globally, and I'm really not going to spend a lot of time on this, but I just thought I would put this in here to think about how we can look at Africa going forward. So, I mean, the profession started in the United States, as Kelly alluded to, and it used to be sort of as part of a role of other medical professions. And then it comes to what is genetic counselling, and that global expansion of genetic counselling starting in the 1990s and became this well-known allied health profession. And in 2010, that idea of having this protected title of genetic counsellor came into effect when the European Society of Human Genetics came together with the Genetic Nurse and Counsellor Committee. And we know that there are lots of healthcare professionals who have been, well, we know that a genetic counsellor is a healthcare professional that has been trained at a master's level, and that's what this protected title of genetic counsellor refers to. But does that mean that we are the only people that can perform genetic counselling? And that's something we need to think about critically. And while we don't want to lose that protected title, in order to look at Africa and the fact that we have so little access, we might need to think about that critically. So to just look at history of genetic counselling in South Africa being the one country that has managed to look at this, and this is from a recent paper published now in 2024 by Tina Wessels and colleagues, and we see that actually in the 1970s, although there was work prior to this, the clinical genetic services started by 2 immigrants into South Africa, one at Wits and one at the University of Cape Town, 2 medical geneticists who started the services in both units. In 1977, we luckily got the buy-in of government at that stage. And I think that is what has helped South Africa grow the profession as much as it has. In 1989 was the first genetic counsellor intake at University of Wits. And in 1992 is when the registration started with the Health Professions Council of South Africa. Sorry, I don't know if this has popped up here. So what happened is that there were medical scientists performing genetic counselling as part of their research, as disseminating information, as well as a social worker who was intricately involved with the genetics department. And these individuals got registration as a genetic counsellor as part of a grandfather clause. Thereafter, there was about 18 months where people could submit portfolios about their involvement with patient care, and then that was reviewed by the Health Professions Council of South Africa to see if they could be qualified as genetic counsellors or registered as genetic counsellors, and thereafter the master's degree training came into play. In 2002 was another important milestone, is that billing codes started to be established, which means that people could be reimbursed for their work, and that is a vital step in the growth of the profession as well. There are many other milestones, and I encourage you to look at this paper. That gives a lovely overview of things. But I thought I would think about the challenges and barriers in genetics in Africa in sort of 4 categories, and this came from a paper from Camp and other colleagues in Africa who said, has translational genomics come of age in Africa? Their conclusion was no, but I think we've got a way to go, and we've got ideas, and we've got this starting, and I think that this all a fantastic step. This was only in 2021, so we have come a long way since then, I think. So if we look at the challenges and barriers in awareness, we know that both patients and healthcare professionals have limited knowledge of the availability and benefit of both genetic testing as well as genetic counselling. I'm not going to go into genetic testing a lot, as Kalinka touches on that in her slides, but we know that there is a lack of education on genomics and genetics in medical training across all training platforms, specifically in South Africa, but I know across Africa too. In Africa, there is usually a focus on premarital counselling, specifically with sickle cell anemia that I've spoken about already. And we know that the general public generally don't really understand what is meant by the term genetic counselling. We also know that there is a lack of awareness of the various conditions that people have, including sickle cell or albinism, and people are often discriminated against or socially excluded. There are many, many funding gaps and lack of appropriate legislative and regulatory framework, and that is usually due to a lack of awareness amongst the policymakers and decision makers in various countries. From an accessibility perspective, we know that in Africa there are huge workforce shortages in general, so there are generally limited healthcare services. Many individuals who I've spoken to coming from African countries to accessing care in South Africa have often not been able to access, for example, blood transfusion due to the high costs in their own countries, and often travel to South Africa due to the better healthcare that they have received here, for example. And of course, if you have general shortages in healthcare, that is only going to exacerbate the accessibility to genetics. And of course, there are larger patient loads within the state-based services across Africa. And of course, then that means that healthcare providers that are already stretched have more limited opportunities to engage with their patients on concepts like genetics. We know that laboratory infrastructure and analytical capabilities are scarce. There's a scarce amount of experts in these fields. And while we are starting to improve that with the research developments that are going on through the likes of H3 Africa, as well as the African Society of Human Genetics, it is still something that is needing to be improved on. There is very poor financial support for genetic testing and technologies, and again, that'll be touched on in a moment. And of course, the scarcity of African data. Of course, we are getting somewhere. The African genomics projects are adding to our databases, but I do think we still have a way to go. When it comes to affordability, we have to think about the financial barriers from this lack of state funding. Also, patients themselves often live in very rural areas and cannot afford to travel for healthcare, often not having transport. And of course, the technology, as already alluded to, those technology costs are out of reach much of the time. If I think about South Africa and our access to next generation sequencing platforms, it's extremely rare that we will be able to access panels of testing. Although that is getting better, it is still something that we have to fight for. And often people are required to pay out of pocket. We are reliant a lot of time on research grants and academic institutions for, funding that gap in laboratory testing and clinical posts. When we use and abuse our lecturers to do clinical services themselves instead of only teaching our students, it's another resource. We also know that the state has competing healthcare costs. The COVID, HIV/AIDS, these communicable versus non-communicable diseases, they really do mean that genetics is not often on the forefront of policymakers' minds. COVID didn't help us, but we are starting to see the rise in non-communicable diseases as HIV/AIDS and COVID are starting to become more mainstream and starting to be a little bit more under control. But we do know that congenital birth defects are the highest in Africa, and actually have, I think they said 94% of the global burden is in Africa. And then, of course, is the applicability of genetics. And it's difficult because we don't often have reliable epidemiological data in Africa. So it means that prioritization of genetic service deliveries that are locally relevant to a local population become quite difficult. In South Africa, there's been lots of talk about what are founder conditions in Africa, what is more prevalent in our country, and then looking to see, well, how do we build newborn screening around that? Not that newborn screening is available, but that is something that has been spoken about. But, we need to have that data more robustly around Africa in general. Then, of course, one of the main things that has been some of the things that we've been thinking about is making sure that we're culturally competent. There are language differences across Africa that is vastly different compared to the rest of the world. I mean, in South Africa alone, there are 12 official languages. Literacy levels are very different. One of the Ugandan papers that spoke about a call to action and the need for genetic counselling in Uganda from 2024 said only 1 in 5 individuals in Uganda is literate. 1 in 5 individuals is illiterate, 20%. And we know that there's a whole load of traditional belief models and religious belief models which are in conflict with the health belief models around genetics a lot of the time. There's a lot of witchcraft. There is a lot of other traditional beliefs that one needs to think about, and one often needs to work with communities and ensure that this is something that is wanted and required. This is a paper that was published about low and middle income countries. And while it included other countries outside of Africa, there were a lot of points that I thought were directly relevant to Africa. They spoke about genetic counselling services, not genetic counsellors, but the services that are provided by healthcare professionals that are not genetic counsellors, being, medical doctors, having a tendency of being directive and referring to, only doing genetic testing if people would prefer perform terminations of pregnancy, for example, or saying that you shouldn't marry an individual if they, for example, are carriers of the same recessive condition. They spoke about genetic services having psychosocial consequences that require improved support. And that is indeed true. And if we're going to expand genetic services, we also have to think about that expansion of psychological or psychosocial services and support systems within those countries. We also know that medical genetics training and undergraduate programs are inadequate. And genetic services are difficult to access, as they usually have been traditionally performed in tertiary centres. And tertiary centres are usually things like university, which are usually very far from, major rural settings, and travel to those settings is quite difficult. So one needs to think about how one can disperse that and get to more grassroots level. The social determinants about uptake and understanding of genetic services will vary across countries, and those social determinants are very important to keep in mind, and that goes along with the social stigma. that is often associated with genetic disease. The family values are at risk of disruption by genetic services, and while that is quite a stark statement, in Africa, where it's not the same as Westernized populations, one has to think about the fact that a lot of our African populations are quite paternalistic in their approaches, in their family values, and often the decision making is not led by an individual, but is often by families, and that is quite different to the Westernized model that we're quite used to. Religious barriers or principles pose barriers to acceptability and utilization of genetic service, as well as cultural beliefs and practices, as I've already alluded to. So what about the way forward? So some of this is from the Ugandan paper, and some of this is my own thoughts, but thinking about political buy-in and allocation of funding. I think back to 1977 when the National Health Act, or the minister at that time, mandated that genetic services were a critical part of the healthcare services in South Africa, and how that has allowed for services to grow. And if we want to expand services in Africa, how are we going to need to try and get some more political buy-in across the continent? And with that goes appropriate legislation, looking at what other countries have in terms of their health acts and seeing where people should be registered. Should it be within allied health professionals boards? Should it be within psychology boards? Should it be within medical boards? Of course, we need to develop MSc courses or otherwise collaborations with other countries in order to train individuals of African descent so that they can go back and offer and start these services in their own countries and grow from there. We need to then think about how Africa could be different and how we could integrate into existing healthcare structures or part of multidisciplinary teams. And this is where I was thinking about mainstream versus tertiary settings, and how we could possibly just fit straight into looking at genetic counselors within an oncology service, or genetic counselors within a prenatal service, or in a pediatric service, versus having an isolated genetic counseling practice. Thinking about how family histories can be used at grassroots level, and seeing how we can then refer forwards. And of course, to do all of this, we need to start thinking about supervision and support and collaboration across Africa. Research budgets, we're often talking about dissemination of research findings and how that really should be done. And unfortunately, because of the scarcity of resources, that isn't being done in Africa. And how we need to now motivate that ethical boards mandate that research budgets need to inherently include funding for genetic counselors if they're performing genetic counseling research or genetic research. And then we also need to upskill other healthcare providers. Genetic nurses, I think, are going to be vital in assisting the development of genetic services across Africa. And just on that topic, I wanted to just mention about some fantastic initiatives that have already taken place, and how we're going to try and see what we can try and build on. We have the African Genomic Medicine Training program that was conceived by the African Society of Human Genetics in Asia Africa in 2016, which I think has had a couple of cohorts of nurses go through. They haven't, unfortunately, published anything recently for me to mention about how that has gone. In South Africa, we used to have nurse training called Medical Genomics or Genetics Education Program, or MGEP, and that was provided to nurses or allied health professionals. And it was a basic upskilling about congenital disorders in South Africa. And unfortunately, that is no longer happening, but there has been lots of talk about that being started up again. And that really just will work in terms of helping to raise awareness amongst healthcare professionals about genetics and congenital disorders, and seeing how those can be referred on. And then there was a wonderful Ethiopian paper that spoke about 2 cohorts of nurses that they upskilled. They did have significant challenges in terms of funding and logistics, but they really learned a number of fantastic lessons, and actually gave some wonderful tips about how they think that nurse education training can go forward. Just a thought that I've been having as I've had 2 students of mine who've worked with telemedicine, and because it's something we've had to do with COVID in South Africa, and we know that 650 million users, there are 650 million users of phones in Africa, which is more than in the USA or Europe. And we know that 89.2% of individuals in South Africa have access to phones. So telegenetics is something that we need to think about in terms of expanding genetics. I'm not saying this is the only way, but of course there are going to be existing challenges that we know about, things like data, network, language difficulties, and being unable to read nonverbal cues. But in the absence of any service, it is possibly something that we might need to consider going forward. And I think this is where the African Genetic Counselling Association comes in. And thinking about the objectives, looking to increase awareness, creating relationships, providing guidance and support to other healthcare professionals that provide genetic counselling service, fostering that active dialogue, and exploring methods to overcome barriers that hinder services in Africa. Of course, performing ongoing research into important topics in the field is going to be important across Africa so that we can publish and let's, see what the priorities are for Africa. And then, of course, to perform high-level advocacy for the recognition and regulation and funding of genetic counsellors in Africa. Of course, we need to provide training opportunities and support capacity building and advocate for our patients. And, of course, strive towards the development of masters qualified genetic counsellors in Africa. And on that note, I'm not going to mention this. I'm going to hand over to Kalenka, who has been integral in the genetic counselling program in Ghana.
Thank you, Nakita. So I'm just going to, for a few quick minutes, just discuss about Ghana, since Ghana is the newest program. I think it's sort of, we'll call it the baby of the family. And so we are still going through a lot of growing pains. And so I'd like to highlight a few of those because I think that can spark some discussion and thoughts regards to some of these countries that are so well developed with regards to genetic counseling, and to look at the scope, because I think it's on now the opposite side of the scope. Will you be able to change the slides for me, Nakita? Thank you. So in 2022, we started this genetic counseling master's program, and this is the first in West Africa. So it was started by the West African Genetic Medicine Center, which is in collaboration with the University of Ghana. It's a 2-year program consisting out of coursework, research, and practicals, similarly to many other programs of genetic counseling across the world. We've had 3 cohorts, and in the image, these are the 4 students that Nakita had mentioned. They have graduated. Their peers of the same cohort are still to graduate because they submitted their research project later. So I'm very proud of these 4s, and they still are to complete their 1-year internship program, which everyone has to do after the master's degree. So looking at how we're integrating genetic counseling into the healthcare system, so because they have been our genetic counselors, the healthcare professionals such as the doctors and nurses have been providing these genetic counseling services, which has been great, obviously, because someone needs to do it. But now it is causing some havoc with us trying to integrate as a professional service, because we are finding that some people are being skeptical about us integrating into their clinic. They are worried that we are going to upset their patients or cause harm to their patients. They don't understand our role as such. I've seen how some of the healthcare providers try and explain to the patients that we are some type of research group of people doing research, that the patients need to speak to us about some kind of research that we're doing. The next and one of the biggest challenges that we face is that the clinic staff are continuously rotating. So we'll have doctors that are working in the clinic doing the training that they're doing, and within a few months' time they shift out and there's a whole new bunch that come in. So there's no way of creating proper relationships with these people, and we have to continuously try and reintroduce and re-educate about who we are and why we're there. And also some of them that have been doing this for so long fail to identify the need for us being there, because they think, well, I've been doing it, it's fine, I don't need you. And then also the infrastructure is quite poor in many of these clinics, and there's no place for us to go. So we'll have patients to see, but there's no room available, or there's nowhere for us to see them. So that creates a whole different problem. Then also, as per any country, there are many different genetic conditions, but sickle cell is one of the more prevalent conditions in sub-Saharan African. 80% of the sickle cell conditions that we have are found in sub-Saharan Africa. So countries like Ghana, Nigeria have a huge population of patients with sickle cell disease. And so a lot of the resources, the time, the research, all the efforts get focused onto sickle cell disease, which creates havoc with regards to us trying to look into other genetic conditions, or focus the finances that we do have onto some other things. And it also has a bit of a skewing onto our training, because now it's easy to access sickle cell patients for counseling purposes and training purposes, but then our counselors are going to be very good at sickle cell counseling, but not necessarily other kinds of genetic counseling. Then our regulatory body is another issue, because obviously if you're new in a country, you are not regulated anywhere. By whom are you regulated? So you have to figure that out. You have to come up with a plan of getting regulated. Once these genetic counselors finish their internship, they need to get a license to be able to practice. Through who are they going to be licensed? Well, first we now had to find who we thought was the right place. And then now you have to be accepted into that. And we initially started thinking that we would use the Ghana Psychology Council for our regulatory body. And that seemed to be fine for quite some time, until they started having issues with our curriculum. And they started saying that the curriculum needed more modules on counseling and psychology related topics. And so because we're not trying to create psychologists, we can't have more counseling than what we already have in our program. And so that became an issue. So we had to look for other avenues. And now we will be licensed under the Allied Health Professions Council. But this is a long, rigorous process, and it actually caused a lot of havoc in actually getting the students into their internship training and everything, because we had this back and forth of trying to figure out what to do. Likewise, we are now getting interest from other African countries where people would like to come and do the master's program, which is great, because we want to expand out into other African countries and grow genetic counseling across Africa. But now the problem is, what happens once they're finished with the master's program? What do they do? Can they go back to their own country? If they're in their own country, can they actually practice there? Who's going to ensure that they are licensed? Is that our responsibility? Is that something they can just do without being licensed? So it creates a whole bunch of questions and sort of issues that we don't know really how to navigate. Then the testing aspect, which Nakita sort of touched on to some extent, it's not mandatory to have testing to do genetic counseling, but it's helpful for many reasons, to try and do risk assessments, to try and get proper diagnosis and things like that. But there's literally almost no proper genetic testing available in the state sector, other than, for example, sickle cell testing. And so the testing, when it is conducted, it goes to a private lab, and these private labs send the samples to other countries, America, South Africa, for testing. And this is extremely expensive, and the national health insurance, and I believe probably in many African countries that have this national health insurance, it's really very dysfunctional, in the sense that it doesn't actually cover half of the things you need it to cover. And so you have to pay out of your pocket, and it's really unobtainable to most individuals. So they can't afford the testing. And likewise for us, when we try and learn about what tests are available, it's as if we need to be private detectives because the labs are not very forthcoming with what kind of tests they have available and all the information about these. Then, as Nakita was mentioning, you know, the knowledge about genetics and genetic conditions is very limited. There's many misconceptions about this. And these misconceptions lead to lots of stigmatization, discrimination. A lot of the patients don't want anyone to know about their condition because it will create problems for them in their communities. There's culture, and religion is a very strong aspect. So these beliefs that people have impinge on the medical management they have because they would rather go and do certain religious practices or some kind of ceremony of some sort, or take some kind of substance that is provided through their religious or cultural affiliation. And so they're not necessarily open to getting engaged with discussions regarding medical management and or open to necessarily listening to what could be medically wrong. Some of the things that we are doing, though, to try and expand genetic counseling and genetics beyond is, firstly, we have the GH Genome project, which is run by WAGMEC also, which is where they're trying to sequence the genome of the Ghanaian population to try and see what the differences are, because we know that the African population have some differences with in comparison to the genome of the European populations. And then they also have a medical caravan, which is what they use for their outreach programs, where they go for screenings, where we're integrating genetic counseling into these outreach programs, where they look for sickle cell, cancers, kidney disease, all sorts of things. We've also started offering all sorts of different courses, like our Allied Health Genomic course, which we did in Ghana and Nigeria. And there's other various courses that we're doing to try and integrate genetics and genomics, and also genetic counseling has started forming part of that. There is a conference taking place at the end of the year for general physicians and surgeons, just healthcare conference, and they approached me saying that they're going to do a pre-conference workshop on genetics, and they would like me to be involved and do some aspects on genetic counseling. And then WAGMEC has created this new building, which is across from a private hospital. And within this new building, they have created a wing for genetic counseling and for training purposes, where we will have offices available for counseling, as well as things like two-way glass, where we can do trainings of sessions with patients and the students to be able to sit and observe things, as well as then to try and leverage onto getting patients from some of these private institutions in this way to also grow the genetic counseling population beyond just the public sector. Yeah, so that's me.
Thank you, everyone, for listening, and sorry if we took a bit long.
Thank you so much, Kalinka and Nakita. That was a fantastic overview of the situation of genetic counseling in the continent of Africa, and I'm so glad to hear about multiple initiatives that are taking place all over the continent. So we are not doing very well with time, so I don't want to waste any further time and invite the next speaker. Can I have Adrian Moreno Ruiz? Adrian, degree in genetics, master in cytogenetics and reproductive biology, also in healthcare genetics. He works at the Genetic and Molecular Medicine Service at the Pediatric Institute of Rare Disease in Barcelona, Spain, and he will be providing an overview of the situation of genetic counseling in Europe. Without any further delay, Adrian, over to you.
Thank you, Mohammed. Thank you, everyone, for having me. Let me share my screen. Can you see that?
I'm not able, yes, I'm now able to see your screen. Maybe we want to full screen it so we see your slideshow.
Is it full screen? It's supposed to be. So can you see it full screen?
No, I still see it as not full screen. It's on the regular slides.
Let me try again. It worked before. I tried again. So now can you see it properly?
It's not full screen, but you can zoom in a bit in the size of the slide, and it will be okay.
Okay, let me try. Okay. Okay, now?
Great.
Perfect.
Yeah, I think you can start, Andrew.
Perfect. So, thank you again. I'll try to be short. I tried to make a European overview of genetic counseling. First, I wanted to start with this slide in my presentation, mentioning this work about the global state of genetic counseling profession. So, genetic counseling profession keeps growing globally, and there are different countries in different stages of development. We know that. So in 2018, there were more than 7,000 genetic counselors in 28 different countries, more than 60% in USA. I think this is a relevant information. So we know there is international heterogeneity regarding training, recognition, certification, registration, and competences. Most training programs are consist of a 2-year master's degree. What about Europe? So briefly, the professional genetic counselor appeared in Europe in 1980, but it is not yet recognized in all European countries at all. There is great diversity also in the organization of genetic services in Europe. So, as well as in the training and recognition of professionals working in genetics in Europe. There is this contributes to the high heterogeneity, perhaps, in genetic counselors' tasks and responsibilities, and all of this in a context in which there is an increased demand for genetic testing and genetic specialists, which is not paired with a rise in the number of trained professionals, at least in proportion. So. Again, mentioning this work of Abacandal, professional genetic counseling is that year in 2018. It was established or developing in more than 11 European countries. There are at least, but nowadays there are more, 8 training programs. And all of them except Masters in Genomic Counseling in Manchester, consisting of a 2-year master's degree, as I mentioned, and formal registration occurs through 2 different programs. In the United Kingdom, it's via the Genetic Counsellors Registration Board, and we have the European Board of Medical Genetics for registration of different professionals working in genetics, in genetic counseling in Europe. So here we can see this table summarizes details of the number of genetic counselors training and regulatory approaches across the different countries. So I wanted to mention the European Board of Medical Genetics as an important tool in order to have good standards of practice and to serve the needs of patients who use genetic services in Europe. The European Board of Medical Genetics, the professional branch for genetic nurses and counselors, created a process for registration of genetic counselors practicing in Europe, and that opened in 2013. So the European Board of Medical Genetics, the aim of this society is to develop and promote academic and professional standards that are required to ensure the highest possible genetic counseling service. This society was formed in 2012 with the aim of establishing professional standards of education, training, and practice in human and medical genetics and genetic counseling. So the activity of the genetic counselors and genetic nurses branch board is mainly focused, as said, on ensuring professional certification of genetic nurses and genetic counselors in Europe, patient protection, works on unified professional standards for genetic counselors and genetic nurses across Europe, and facilitating professional mobility. So this board, this division sets criteria to evaluate formation and competencies of candidates. Also considering the accreditation of professionals with a long professional career and no formal training. The European Board of Medical Genetics reviews the curricula of European master's programs to assess whether they comply with professional and educational standards. The standard training and education for a genetic counselor is a master's level, theoretical and practical training. However, there are many experienced health professionals, we know that, without a master level degree that are currently working as genetic counselors. And they have various backgrounds, such as midwives, nurses, psychologists, etc., and from the life science. So for this reason, there are different routes to achieve professional certification. And I won't go into detail. So let's move on. There are requirement. Here we have a table again from this paper. Those are the requirements for credentialing in Europe, and those are in Europe an approved master's program along with 2 years postgraduate work, reflective essays and case studies, case logbook, and references. So another important issue is how the role of genetic counselors within medical teams is evolving across the different European countries. So we know that the field of clinical genetics, which used to be just responsibility of medical doctors, has evolved into a multidisciplinary service, and with non-medical professionals that are also part of the teams. So there have been many studies that focused on what the genetic counselor adds to the medical care. At present, the activity of genetic counselors in many countries is clear and well defined, especially in America, but genetic counseling is still a much debated profession in some countries in Europe. There are conceptual similarities in the practice of profession of genetic counseling, but there are different patterns of training and practice. Some of these differences include different modules, different regions and areas of training, and different differences in university background, for example. And there are, of course, also differences in the way professionals are registered with professional boards. So here we have some of the studies addressing what the role of genetic counselors is and how this role has been changing. And from these studies, it can be concluded that the role of the genetic counselor is considered important within the team. Close collaboration with the genetic counselor increases their awareness of our value. The care of patients in clinical genetics could improve by the complementariness within the team. And it seems that there is agreement with the fact that tasks with more psychological implications are the responsibility for genetic counselors working in different countries in Europe, whereas tasks with more medical implications are the medical geneticist's contribution. I wanted to mention also, without going into detail, I'd like to highlight the importance of the role of genetic counselors in reproduction genetics, where the role of genetic counselors has become a key element because of many recent challenges in European countries: implementation of expanded carrier screening at the preconceptional level, detection of chromosomal mosaicism in the pre-implantational genetic testing, and the use of NGS in prenatal diagnosis. Those are some of the challenges that raise many ethical, technical, legal, or social questions. So what about future directions? Genetic counseling remains a growing professional globally, and it is expected to keep growing. So professionals' activities have been and still are developing in accordance with the services needs in national context. So flexibility, how the profession develops and how the professionals are promoted and how this profession expands is necessary given the international variation in laws, health systems, and cultures. International collaboration and growing reciprocal agreements will obviously help to improve training, regulation, and practice of the profession. It is known that the advancement of genetics is recognized across all medical fields, and therefore it could be appropriate to have access to genetic counselors in every different and separate specialty. It is clearly a major issue to harmonize academic requirements and training, and there is an ongoing debate on which university background could be the most appropriate for this profession. Some authors suggest to unify on a European level the degree classes that can access the specialist training to become a genetic counselor. Also, of course, technological progress, without going into detail again, has led digitalization to be a fundamental tool in the field of genetic counseling. And of course, we need more research in the future, also by interviewing not just professionals, but also patients, with the aim of moving towards a personalized medicine that puts the patient at the center and improves clinical outcomes and quality of life. So this is all for me. Thank you again. And that's it.
Thank you so much, Adrian. It was quite well kept in terms of time. We also got a very important overview of the status of genetic counseling in Europe. And now, without taking any further time, I would now like to invite all our speakers, Nakita, Kalinka, Adrian, Kelly, and of course, one more person that I have not introduced is Milena Paneke. Milena is based at the University of Porto in Portugal. And Milena is also she's a genetic counselor and founder of the MSc program at the University of Porto in Portugal. She's also a Professora Auxiliar Convidada. I hope I pronounced that correctly. And she's also a European registered genetic counselor. So we will have on board Nakita and Kalinka representing the African Genetic Counselors Association. We will have Adrian representing Barcelona, Spain. We'll have Kelly from Zurich, Switzerland, and Stanford. And we have Milena Paneke from University of Porto in Portugal. Thank you so much for being on the panel. Perhaps you could switch on your video camera so that our guests can view you. I hope it does not take too much bandwidth. And I simply want to jump into the topic where you probably know we're going to talk about different sessions. So the first thing I really want to touch upon, and I am sort of pointing out to 3 people here. So I want this answer from Kelly, Kalinka, and Adrian. What do you think are the primary differences in the genetic counseling training programs between Africa and Europe? You can go in any order. Maybe we can start with Kelly, and then Kalinka, and then Adrian.
Sure, I'm happy to start. I think, when I look globally at the programs and the differences, I think in the places where genetic counseling is newly emerging, the programs end up sometimes having more of a scientific focus than the counseling focus, and that sort of expands over time, so that, in comparison, when you look at things like the US and the UK and Australia, they end up with quite a lot of counseling material, and newer places. So even to use Italy as an example where I teach, they have 1 or 2 courses throughout the whole 2 years that are counseling based. And the course that I teach there is the equivalent of like taking 6 courses and smushing it into 1. So that I think is the first thing. And then the second thing, and Nakita, this will probably resonate with you, I imagine, is when you're in a place that you don't have that many clinical genetic counselors to do the supervision, the training ends up happening in a very different manner. Maybe Kalinka can also expand on this, because you just don't have 50 genetic counselors there to talk about how they work with patients, and you end up relying on 1 or 2 medical geneticists. So those are 2 key things that I would want to point out.
Excellent. Kalinka, you want to go forward? And then Nakita, if you want to come in, feel free to do so.
Yes, I agree with
Kalinka.
Kelly. I think with what I'm seeing is that maybe there is a little bit more of the counseling aspect, but this is because the people that that formed this course, we have a combination of laboratory scientists and psychologists that came together to create this. And so what is lacking is the actual sort of clinical stuff. So yeah, I think based on the fact that there are no genetic counselors that are helping or that are creating these courses, putting them together, the content of what is being taught looks a little bit different than programs that are already established with genetic counselors who are actually creating what needs to be done. And I guess, yeah, I think also just sort of enough a capacity of trained people to actually, like she was saying, do the work. I think the thing is now the people on the course that I'm doing, I'm the one who does all the practical training. I'm doing, you see, there's 3 cohorts of students, 7, 5, and 4. It's a lot of students for one person to undertake, and so it's impossible to do a thorough job of practically training so many people at once with one human being. I can only be in one place at one time. And so I think, a lot of the practical work, somehow it happens like self-training, and then you get the first group to help to train the next group. And so I think it's not as thorough of a job than if you have, like what Kelly was showing, 50 genetic counselors. I mean, how many students there's ample amounts of time to care for a student if you have 50 counselors who can do so, Yeah. So I agree with what she said.
Absolutely. So, Nakita, want to weigh in your thought?
Yeah, I was also just going to say the other difference I find is as we don't really have access to testing, I find that Europe often has a lot more access. So you have a lot more technology that you're sort of focusing on and technical training, talking about even pre-implantation genetic diagnosis, NIPT. That's not a thing in Africa. So we rely on the basics. We rely on risk. We rely on a lot of pragmatism versus access to technologies. So how can we work with those intimate skills, that were the original skills, if I can put it like that, versus those texts. But we still expected to keep up with the world. So it's quite difficult to balance those things.
I sort of want to build on the same question, and I'm bringing the two of you back on the spotlight, Kalinka and Nakita, because both of you work in the continent of Africa. How would you, or what would be your perspective on how we can improve the accessibility and the quality of the genetic counseling education in our continent?
Maybe I'll start. I think the quality of the education, I don't think is necessarily going to be a problem, because we do have some people that are excellent, but I do think that it requires collaboration. The way Ghana started is that they collaborated with WITS and with UCT, and they got lecturers from both of those programs to assist with setting up the Ghanaian curriculum. And things like that, those discussions and talks will be useful for other programs to start to say, what are the basics that we need to make sure that every genetic counselor knows how to do. And I think then if you have I think most people in Europe or Africa are willing to do a 1-hour lecture online. Those sorts of things are definitely things that I think we definitely can collaborate on and make sure that we get a solid training in Africa. I forget the other part of your question, so maybe Kalinka remembers. Or has other
I'm
ideas.
talking about more like the accessibility. So you mentioned already, talked about the quality of genetic counseling,
the accessibility,
but also about
counseling.
how we can accessibility, like how do we make sure that the program reaches as many people and as widely as possible. Kalinka, you want to weigh on that?
Yeah.
I think one of the things for me is finances. So what I'm seeing since I've placed myself now in Africa, what I'm seeing is a lot of people, particularly now within the African context, they don't have the finances to do a lot of stuff. And so what they're doing is they're looking for programs that are funded. Like we have a lot of applicants every year where when we interview them, it doesn't seem like they know much about genetic counseling, but because there was funding available, like scholarships available, this is where they find themselves because they don't have the finances to study. So they try and land wherever they can where there's something that's financed. And so I think the accessibility where more people would be able to get involved or try and study, or where we can sort of cross borders into other countries and things like that, is if it becomes more financially accessible to be able to firstly study, go to wherever to study, and then also like for the country then to have funding to create such a program. The reason why Ghana has this program is because the director is just he is also based in the US but also in Ghana, and he has a capacity to get grants for things like this. If you don't have that access or that know-how to get large grants to be able to create such programs, you're not good. How are you starting up such a program? It creates a lot of challenges with regards to that. So I think the accessibility comes to the finances that can help to grow these things.
Right. And of course, training programs are equally important, but at the same time, to really make a training program be accessible, be something that's of high quality, we definitely need to talk about collaborations, international collaborations. And I think I want to pull in Kelly once again and Milena as well as Adrian. Perhaps, you could share some examples of successful collaborations between not necessarily African, European, but globally, successful collaborations that happen between institutions on how African can draw lessons on how to train genetic counselors using that collaboration as the spirit.
Yeah, I'm happy to start with that. I think that one of the things that some of the US programs did was start what we kind of called these sister programs, where, for example, Stanford partnered with the Philippines when the Philippines program was just starting. And every quarter we would have these phone calls back and forth where groups would take turns presenting cases and how they managed them in the clinic. And the Stanford students learned a lot about some of the information that the Philippines genetic counselors were conveying and how the cultural issues were working and some of the challenges. And then the Philippines genetic counseling trainees learned about how cases were being handled in the US. So there was a nice exchange, and we provided resources back and forth. So this would be one idea as programs get going in different places in Africa, would be to tap into those many genetic counselors in some of these other countries who might be willing not just to help with lectures, but to have that more interpersonal networking between the trainees, or even to provide clinical supervision in some of the ways that may be an issue. The other thing I was thinking about was in Austria. I know that their German-speaking program covers individuals from Germany, from Switzerland, and Austria, and they have taken people who are, let's say, working in a laboratory, for example, or have other jobs, and the job will sponsor them to come part-time, maybe once a month, to Austria for their training. They get the curriculum there, then they go back and they do their clinical work and their research projects in their home country at their home site, and they're responsible for that funding. So Kalinka, maybe that's another model that some of the countries in Africa could consider to send people to you or to some of the South African programs where they'd actually go back and maybe have a job, right? That's part of the challenge.
Absolutely. You want to weigh in?
Yes.
Elena?
I think the AGC have been doing a great job, because this is a kind of channel among all the educators in genetic counseling. So we have been trying to put together a similar idea to this specific example that Kelly mentioned about the sister programs, so that we can share not only materials for education, lessons, conferences, but also, for example, typical tests, typical role models, clinical contexts, research topics that we can put together students looking at the specific issues and comparing different contexts among the countries. I think all this helps a lot, because we are just a few around the globe. So we need to be doing these kind of seminars, webinars, putting people together and try to make that bridge among the educational programs that already exist, or supporting others, because Kelly mentioned she's teaching in 2 European master programs and she was trained in the USA. So we need that kind of efforts supports the development of genetic counseling in countries where there are no genetic counselors yet. I think Portugal can perhaps helps more in some European and African countries because of the language as well. I think it's very important to be aware that the language differences is a great, a big barrier that we need to take into consideration, to teach and to observe consultations and all this. So perhaps our master program in Porto can help a bit more and exchange students with the Portuguese language as primary language. And I will remember other examples, but I would also mention the efforts of the European Board of Medical Genetics, because they have been trying to put together some international agreements for making possible this kind of exchange, so that Kelly can be practicing in Europe and have an European accreditation, for example. And this also is vital or essential for the development of genetic counseling, because otherwise we will be the same in the same countries. We need new people already trained, trying to start or to develop, foster education, research, regulation, using their own experiences. And I think it's very important to have these kind of channels or conversations like today.
Absolutely. Thank you so much. And indeed, you're absolutely right. We need to also consider the languages when we talk about, international collaborations, because sometimes that is so important when you take into the cultural sensitivity and the context of it. Adrian, you want to weigh your thoughts on this issue?
I totally agree with Milena and everyone else. I was thinking mostly on this collaboration within training programs, for example, and I was going to mention this about the European board to facilitate that trained counselors outside of Europe can then practice, develop their practice in Europe. So I was thinking mostly on promoting professional mobility. I think this is quite an important thing to improve recognition and training of genetic counselors. Yes.
I would say support, financial support is really also important, because some of us have a lot of willingness and put a lot of effort in doing initiatives like this, but it's the same person for all the activities, or so we need people already paid or put in the right places for making all that possible. Otherwise, it's like it's not enough. Our willingness is not enough for developing something and maintain an idea or a project along the time.
Absolutely. And I think, just sort of going from training to collaboration, I want to jump into professional recognition and legislation. Now I know, and I'm going to bring all of you in this conversation, because this is something that's super important. But let me start with Nakita and Kalinka from an African perspective. What do you think are the key sort of legislative hurdles that are faced by genetic counselors in Africa? And of course, how is this profession of genetic counseling differently recognized in Africa compared to other parts of the world? Your thoughts on that?
So the key administrative hurdles, I think there's such a thing called African time. And I think things do tend to work a little bit more slowly sometimes. Having actually served as the genetic counselling representative on the Health Professions Council of South Africa, I do know there is a lot of I want to say politics involved with a lot of these legislative hurdles, but people are actually trying their best, and people are actually wanting to try and get these boards going, and one just also has to be patient. So I think some of the hurdles are that initial sort of, so getting your policy framework upright, making sure that your acts, if you have a health act, that the profession follows that act. So for example, our Health Act stipulates that all healthcare professionals are supposed to do a year's community service. Somehow genetic counselors got excluded from having to do that in our country, in South Africa, for example. And I actually want to ask South Africa to make that reversed, because if I can institute community service that gets paid for by the government, I'm going to get more people jobs out of graduation, and we're going to get more people then being exposed to genetic counselors at a grassroots level, at a community service level. And therefore, innately, that's going to start to build that awareness and start to build that job profile that doesn't otherwise exist, because otherwise genetic counselors just in tertiary centres. So that's one of the legislative hurdles that I've been thinking about. And but then, of course, we need the buy-in from genetic counsellors. I mean, I was on the board, I want to say 10 years, no, not 10 years ago, maybe 8 years ago, and we had changed some of the documents. Those documents are still not passed. So like that kind of, when I say Africa time, there is such a thing as Africa time. Kalinka, I don't know if you want to weigh in.
Kalinka, you want to weigh in your thoughts on that?
Yeah, I think I already sort of touched on some of that in my talk, but I think that's the thing. It's a bit of a issue with regards to sort of getting these boards to accept what you're telling them you are, or who you are, and how you would fit in. Because when we were creating all our documentations, for example, they looked at all the documentations of this is what we're saying that the people need to do in order to be able to register as a counselor. These are all the criteria. This is what a genetic counselor is. This is what a genetic counselor is supposed to do. They look at these things and then they make edits on these papers and they send them back. And then you're like, but you can't remove this thing, or you can't change this description that we're giving you. I mean, this is ours to create. And so like it's a back and forth argument now with these boards to try and get them to see, okay, this is where we're coming from. This is who we are. You can't decide for yourself who we are and then try and fit us into this sort of cookie cutter thing that you've created, because that then changes the whole dynamic of where we're coming from and what I mean, we can't change our genetic counseling students to do something completely different just so that it fits into your regulatory body or your idea. And so like, I think this is the challenge of finding the right place and then having that acceptance of like, these people are accepting what we're saying we are supposed to do as genetic counselors and how we fit in and what will work and what shouldn't work.
I think this is what is happening. Yes,
Mhm.
this is what is happening in many European countries. We wonder what is the breaking point of all this, because how others have managed to have already integrated, and we don't want to spend the whole time that the other countries spent in this. So, for example, in Portugal, there is a lack of understanding of our role, a lot of misconceptions, some professional things we were not right starting the master program because we don't have the regulation or the integration of the profession, but you don't know what is first, the egg or the chicken. So it's like we don't have the specific regulatory body. We don't know to whom to ask. We have been trying different strategies, joining the parliament, through some of the deputies, through the Ministry of Health. Now we have the support of medical geneticists and the Order of Medical Order. We are not able to have our own order because we are just a few, but the most close orders like psychologists order or nursing orders are not endorsing our specific competences because perhaps they feel we are like very similar to them or close to them. So I think, again, as a founder of the European Board, something that I still have in my heart, that we need a lot international indicators, regulations that support all the countries in the world, that say this is not an option, this is really mandatory to develop not only our profession, develop genetic health care for patients in the world. So why, if there are a lot of genetic counselors in USA, in some countries already providing help to families and people affected with genetic conditions, we still have in other countries? I think this is an ethical issue globally of access to a vital human right to have access to good health care. So I think we should look at this as an international issue. And the European Board made a lot of efforts trying to put together position statements and things like this. In some countries, they need to have the indication of you should have this person professional in your genetic healthcare services. This is a law, this is a regulation. Otherwise, they will not start. It is like they are afraid or they don't have enough about the profession, but I still having this I'm convinced that it is important international regulation and indications or statements about the role we have and how we can be relevant for preventing, personalizing medicine overall. It's otherwise will be national personal efforts.
Right. I actually want to bring in Kelly on this particular point, talking about genetic counseling from a global context, and you've given us great examples on the number of genetic counselors purely based in the United States, but also in China. What would you think went right about them? So, what is it that they have done that that actually enable them to successfully navigate the legislative landscape to support genetic counseling? And on the same note, what kind of advice would you provide to not necessarily Africa, but generally to lower middle income countries on how can we use that to integrate genetic counselors into the healthcare system? Because I think that is also a huge problem in the continent, the lack of recognition of genetic counselors.
Yeah. Well, so Mohammed, the first thing I'll say is that in the United States, for example, which is the place that I know the best since I worked there for 25 years, they've been working on this for 25 years. So, I mean, to speak to the comment Nakita made about how long it might take in Africa, like they still don't have national recognition in the United States after trying for 25 years with all of these people.
25 years.
And they had to go state by state to get, I mean, every single state in the United States had to get licensure in order to then have some mechanisms to bill, and they still only have, I don't know, like 35 out of 50 states maybe have licensure. So it is a long process. But I do think that I will echo Mile's points, which are that we need some international groups to, we're never going to be able to regulate internationally. That's like, don't even try to do that. We all know that's not going to work. But if we can share things together, and I know, for example, in Switzerland, we were trying to get recognition for genetic counselors, and we took materials that the US had made about what is the scope of practice, what does a licensure law look like, what does the regulatory bill that they've been trying to pass look like, and share those across borders, where then people can say, okay, this will work for me in South Africa, but maybe like in Ghana, that's not going to work. How do I tweak that? What are the things that my country thinks are important? How do they regulate things? You know, in the same way that maybe the European board has people do portfolios for assessment and regulation. The US is never going to buy that because that's just not the way they license medical providers. They only do it by exam, for example. So there's going to be these international differences, but I still think we can learn a lot and help each other in a much better way. And I think my advice to the low and middle income countries is to actually start doing that in parallel as you start the profession, because it becomes such a significant barrier. And of course, in the US, it just evolved at such a different pace that it wasn't until we had like this core group that we said, oh, maybe we need to do this to like get some money to pay for our jobs, right? It started off that everything was funded by research projects, you know, in the 70s, 80s, early 90s even. And then it was like, oh, we can't hire more people because we can't ever bill for your services and you're just this lost money. So if you start them in parallel, maybe it will happen at a pace that, I don't know, we can actually pick it up a little bit.
Right. Kalinka, your thoughts on that? I mean, you've been in South Africa and you've sort of, enabled the practice to actually into fruition in Ghana. What will be your sort of ideation of how do we really expand now from these two countries into the rest of the continent?
Yeah, I think this is where the tricky thing is to expanding outwards into other areas. I think there have to be collaborations that are made with the right people in other countries. People at higher rankings than just someone who's particularly maybe interested, a doctor maybe that's interested in. There are many individuals in these African countries that are interested, but we need to find the people, the influential people in other countries who have the resources to be able to drive training into other countries. So whether it's someone who can look at trying to create their own program, or to just create platforms for more awareness, or to they have to have resources. It can't just be just trying to get people who are interested and speaking with them or collaborating with them. We see sort of a lot of what was mentioned before, like this politics is like a big issue in Africa, and if you don't get to the right person. So for example, with a lot what's going on with WAGMIC and what they do, they literally go to their presidents and their they're people who are high up in the rankings, and they're making collaborations with these people, and they have like these big traditional sort of rituals or services or ceremonies that involve these people. And that's how, like, for example, the GH Genome Project, they had this huge thing, and the president was there, and he came and introduced the GH Genome project and all of that. And I think with us, we need to try and find those people in other countries that have the right connections for us to be able to try and work to create, either programs or, things like that. Otherwise, like just talking between, okay, we're going to do a little course here or a little bit of discussions here, it goes to that point and then that's where it stops again.
And Milena, the other question. So we're talking about technological innovations and how that really has improved genetic counseling, and of course that's becoming a significant part of how we process these things. So could you weigh in your thoughts, Milena, on what are some of these latest technological innovations? And Nakita, to you, how can we then implement some of these innovations into resource limited settings like ours?
Of course, we will talk about genomics and how even the definition of our profession is moving to genomic counselors. But I'm perhaps not the best person to comment on this, because I'm still thinking that genetic counseling definition or name for our profession is how to say, focus on the counseling part and not on the specific technology we use is more important. And of course, I don't know, Kelly, if you want to comment on the critical components, but I think the focus, not me, but the focus still being in the way we engage with patients, trying to help to understand and to adapt to the condition. And of course, the technology is the way we go to the diagnostics. But you are right, technology is here, genomic is past, and genomic era is changing all the
But I think
healthcare.
if we look at COVID, one thing that we really understood from COVID is that we now are doing telemedicine. We're doing genetic counseling through a phone app, and so those things are absolutely kind of helping us to do our jobs where we are not physically able to see the patient. So I think there is quite a lot of innovation that's going out as far as counseling. Yes. Nakita, your thoughts on how that can be implemented?
You are part of the speakers of the round table. Let me just to comment on the Kalinka previous talk and related to your input, and thanks for that. I was thinking on the technology for diagnosis and not for the way we provide consultation, and of course. But I think it's important right now for you in Africa and for every single country, but the ones that are starting to provide evidences on the specific cultural or organizational issues you are facing, providing genetic counseling there, the way your population accept your service provision, the cultural aspects, the perceptions, all this is important for mapping and making more robust genetic counseling provision in your own country. Because this is for me, it has been important here in Portugal. We are not genetic counselors at genetic services yet, but we have been producing a lot of evidence on how relevant we are, how the patients accept or expect, what the patients expect from us, how they benefit from our intervention in some research project. But it's important to have this. And again, to map or to study how the telemedicine have arrived, or telecounseling have arrived to our healthcare provision, and how it changed a lot the way we talk and exchange with patients and relate with them, because of course it's very different. And there are a lot of master programs already integrating lessons about it, the things we need to take into consideration, what the evidence is saying about the new challenges and the way you engage with the patients and they understand the information you provide and all this, of course, is also important. Sorry, I try to combine both the previous thought and the
No
new
worries.
issue.
No worries. Nakita, over to you on
Yes.
how we can implement that.
The innovation. So I was just thinking about that. We've actually done quite a few of these in South Africa without realizing that they're innovations, to be honest. So I mean, the use of telemedicine or telegenetic counseling, I mean, as a society, the GCSA has actually put out guidelines of how we recommend that gets done in South Africa. And so we're using that more and more. For example, in our setting at UCT in Cape Town, we do a large service on risk counseling for advanced maternal age. It's the only way we have to screen our state patients. We don't have first or second trimester screening. We use age as old as that is. But it's because of COVID, we've actually now sort of streamlined that quite significantly to say who is interested, who is not interested. And we actually have these electronic platforms for referrals. So these, they're coming from the primary healthcare setting. They send a WhatsApp referral or a form that we've given them that they take a photo of and WhatsApp it, or we've got this app called Vula. And it's actually there's another one called Cares that is coming, and everybody in the state-based sector has access to it, and they just send, this patient is 45 years of age, please, here's their phone number, and we then phone and see, are they interested in genetic counselling for their age-related risk or not? And if they're not, we don't bring them all the way into a tertiary centre, which costs them time and money, because in South Africa, if you don't work, you don't get paid. So it's quite a lot of money if people say, I'm not interested in that kind of service. So that's one thing that we've been doing quite well in our setting. Obviously, it is quite tricky from time to time. People share phones, people work, they don't answer their phones, data, certain people can only be contacted on WhatsApp, some people only on SMS. So navigating that has been tricky. But the other thing that I was thinking that my colleagues at Tygerberg did just up the road from us is they actually developed a video for age-related counselling and then translated it into the local languages here. And then they would play that in the waiting room. So then so the patients got all the information in this video that was really well made, and then they would bring individuals for decision making, and the consultation would maybe be 15 minutes because they would do the family health history, making sure there's nothing else to be concerned about, but the patient was already primed for what we're looking for, and then primed about how they would decide, do they want invasive testing or not for their pregnancy. So, seeing these huge volumes can certainly be decreased with these kinds of technology that can be adapted then for languages that you need. And that's certainly something that we've been toying with, collaborating into other languages all over Africa. So those sorts of things are definitely things that one can try.
Absolutely. And of course, when you talk about counseling, one can't really overlook the issue of culture, the issue of language, the issue of the fact that we believe in different things. So I want to sort of pull in, Adrian, your perspective from the Barcelona, Spain side of things, Kelly from the States and Zurich, Kalinka from Ghana, South Africa. How do you see cultural perceptions of genetics and genetic counseling differ between these? What strategies have been effective in sort of addressing the cultural barriers to genetic counseling where you're based at? Let's start with Adrian, and then I'll get to Kelly and then Kalinka.
Sorry, Mohai, can you repeat the whole question, because I heard you.
Sorry. All right. So we're talking about cultural perception. So how does the culture really affect the way you perform genetic counseling? And what are the best strategies that you are using in your own practice to address these cultural barriers? Sometimes, that would have an impact on how people perceive their risk scores, or maybe the fact that, for example, NIPT and those kinds of things. How do you deal with that?
Yeah, so I think the cultural aspect is very important. And for example, from my experience here in this hospital, the kind of patient and their social-cultural background is really different, and I think we have to do an important effort to adapt to the background of each patient. Not just talking about language, but even we were talking about technology a few minutes ago. So I think we should adapt and personalize. So this is also part of personalized medicine, just to adapt our profession or our practice to sociocultural background of patients. And talking about technology, I wanted to add also, so the artificial intelligence also is here, and this is helping us communicate to patients, but we need to be careful also. I think this can be quite dangerous, so we need to validate also each each tool developed in this sense. So we have to find a way to integrate this as part of our daily clinical routine instead of being replaced, of course. Yeah.
Kelly?
Yeah, a couple of quick points. I think the first is that we should always strive to have our workforce reflect the population we're actually serving, right? And I think that's our best way to know that we're matching the cultural issues and the linguistic issues and things like that. But that is, of course, one of our biggest challenges everywhere around the world, is to find ways to get to that point. And I think that in the meantime, we can focus on things like, what is the right language and how do I get materials into that language? Probably we're going to be better off with audio or video related educational tools rather than written educational tools, simply because of the literacy issues that we heard about earlier. And I think also, building on Adrian's point about using some of the AI related things, we're in the middle of doing a research project where we tried to use ChatGPT to actually generate like patient education materials for us in different languages. And as soon as you leave English, the ability for it to get it right just crashes. So we tried with examples of writing the prompt in English and asking, just write it in these other languages. And we were only sticking with like Italian and French and German and Greek as some European examples. And the minute we left English, it got significantly worse as we kind of went down. So we do have to be really careful about that. And we need to help AI get better trained if we're going to use it in those kind of ways to say, oh, I've got this patient who speaks this language. I'm just going to ask ChatGPT to give me something good. It might not be. And if we can't read it, that could be a real problem. And then I think the last thing I'll just sort of flag is that there's lots of cultural differences about how much direction patients want and what they're used to from their medical care providers. It's more sort of, I hate to say westernized approaches to autonomy and direction aren't always going to work. And we have to, again, sort of rely on knowing in the countries that we're in, like what really works here and how can we modify the principles of genetic counseling to work in these places, and just be a bit more open-minded, I think, about that. So I'll stop there.
Right. Kalinka, you want to weigh in the African issue?
Yeah. So just to add on to what Kelly said, just something she said just sort of triggered a feeling in me, because coming from being a white woman, now working in a predominantly Black environment, you can see the dynamic change when I'm in the setting, the counseling setting. There's just some of the sessions, the dynamic is completely different than what you would expect. But just to add on to what she said, I think another thing, just one of the things with these people that come with sort of these preconceptions from their either religious or cultural background, is to not be dismissive of that. One thing I've seen is how the doctors will be very aggressive in their approach. Like, this is a medical thing. If you don't take this medicine, you're going to be sick, and that's your own stupidity or whatever. And this kind of just has a whole kickback in the patient. Like, it just creates like this big barrier. Whereas if you're less dismissive of that, and kind of try and combine the two things, combine the medicine, provide those medical facts, but be accepting of, if it helps you to pray, if you think that praying is a good idea, pray. Maybe it will help. Maybe it's a good addition to taking the medication. So maybe you could take the medication and you can pray. Or maybe if you have to take this this concoction of stuff that you make, unless it's harmful to you, unless it's going to create some more medical issues, take it, drink it. If it's not harmful to you, why not take it, but then take it with the medicine you're supposed to take. And so combining and not being dismissive of a person's background seems to create an environment where they're more willing to listen and more willing to accept what is being told, or what information we want to give them. And so that's one of the main things I've seen.
Right. I want to bring in Milena to this discussion, and one of the things that apart from culture, that's also important is, I think Kalinka briefly touched on it, is also the religious aspects. And sometimes there are certain decisions based on, of course, the kind of testing one undergoes. But assuming you're talking about a non-invasive prenatal diagnostic test, you find out a lady's pregnant, carrying a baby with potentially Patau syndrome. We know that child probably will not last, will die in the early stage right after it. Now, you are in a position where your role as a genetic counselor is to ensure that you've given them the right knowledge to make their decision. You're not supposed to make decisions for them, but empowering them with the right kind of knowledge and information that they're able to make the decision by themselves. But then here's somebody who comes to you, Milena, in your office with a copy of the Bible, or if she's a Muslim, then a copy of the Quran. And they tell you that abortion is absolutely illegal, not allowed. How would you approach such a case? Milena, you're muted.
Sorry, this is a very specific question, but I will perhaps start from before, because I think cultural aspects are part of even the way you receive your patients in the waiting room. So you need to be aware, and we try to train our students in such difference, that not only religious, but also the way they accept personal contact, the way they accept who make the decisions in the family, and all these change a lot the way you approach them in the consultations. So you cannot be empathic if you don't know how they think or how they take their decisions. So in that case, I would be, of course, trying to offer them the possibility to discuss the pros and cons, and try to reach a decision according to their values. But of course, the decision is more complex when there are issues for the vital for life or things like this. The decisions they can take in terms of how they are approaching the hospitals or things like this. We don't manage this in our consultation, at least, but all this should be together in the way we talk to them, hear them, and suggest them to think and reflect about the options they have. It's we don't have, for example, translators. Sometimes we are not able even to understand properly what is the issue. And all these interfere the way you understand them or help them even. I'm a person who, I'm not Portuguese, for example. I'm from Cuba. I was trained in Cuba, and sometimes there are things that I don't kept enough, I think, and all the time I have this in my mind, trying to be open and to let them to be free as much as possible to clarify something that I don't share properly or that I wasn't clear enough. But sometimes this is a challenge in the way I understand their previous experience. Of course, what Kelly mentioned, what they expect from me is different, because there is also a very directive relationship with doctors in Portugal. This is part of our culture here now, that they assume we are going to say what they need to do. And when you start your consultation saying how I can be helpful for you, they stay like that. Well, I start, nobody asked me how they can be helpful for me, because I assume they are going to say what is helpful for me, the difference. And this is So all the time we need to be aware to try to understand all, not only the cultural, the religious, but all the personal life our patients have in front of us, and that is making a role in the way they decide about the test, or about the way they are going to manage the condition. Not always is a question of a test. Sometimes it's only a conversation about how to manage the disease. And it is also
right.
impacted by the way they live, the way they organize their own families, their own traditions. This is very complex,
Right, thank
Mohammed.
you.
This is
Absolutely complex. And this is the reason why I bring it up, because I think it's important to touch upon these critical aspects so that people understand that the counseling bit is a very complex procedure, and that requires a lot of psychological thinking on how you want to approach a case from an angle, and how many dimensions you really want to open up. So I am very, very cognizant of the fact that we are over time, and I will try my best to stop at the half-hour mark. So I'm going to end with one last question, and I will allow 1 minute for question, and with that we will then complete today's webinar. Question is more towards thinking of the future. All right. So this is a question for all of you. What do you see as the most promising sort of future direction for genetic counseling globally? And of course, how do we ensure that whatever advancements we're making in genetic counseling, whether you are somewhere in Madrid or somewhere in Dakar or somewhere in Dar es Salaam, that it is that particular practice is inclusive and it benefits populations all around the world? I'll give each of you just 1 minute. We'll start with Adrian.
Okay, thank you, Mohammed. I think this is difficult to answer. I think, yeah, I think the future of genetic counseling is promising. There's a lot of evidence that this is a growing profession. It's true that there is high heterogeneity across the globe. So I want to mention what Milena said before, the importance of international alliances, initiatives to work together in the same direction. Also, I think the future is going to have a lot of technology in our profession, and I think this can be promising, as well as Kelly was saying before, also can be dangerous. So this is something that we're going to have to deal with. And of course, webinars and sessions like this make this really promising, because we have the opportunity to learn from each other and learn from different perceptions, from the professional point of view, of course. And I think this is really enrichful to all of us. Yeah, for me at least.
Thank you so much, Adrian. Kelly, you want to go next?
Sure. I think Adrian understated things significantly when he said this was a difficult question, because if it wasn't, we would have solved it already. I think, in order to reach this goal of having accessible genetic counseling that's equitable across the whole globe, we're going to need to be really creative and flexible, and it's not going to be one size fits all, I think. I know that it is controversial in many settings, but I personally think that the only way that this is actually going to happen is moving away from the close ties to medical geneticists only and getting into more mainstream systems, whether those are the community health centers or the specialists who are caring for people with different diseases. I think that's going to have to be part of this. And I think that we're also going to have to be really creative about who we train to provide genetic counseling services, balancing who is a genetic counselor and what services they provide with what are things that we can train and upskill other people to do, and not feeling possessive about that, because there is so much genetics to go around that we can all have a job for our whole lifetimes and not worry. And I think we just need to focus on how we can get all this information out there and really just kind of think about how we can do it in a way that will mean whatever someone is doing, it's going to be high quality, and we've helped train them and help teach them and help connect them. And then we just keep pushing forward, and it's going to be bits and pieces. So I think this, again, is a great start, as Adrian said.
I think it will.
Thank you so much. Yes,
Sorry.
Milena, you want to go next?
I think.
Yeah, go ahead.
I agree with Kelly and Adrian. I think in the short future, we will be responsible for protecting our job title and competences, because there are so many new professions or activities in the context of genetic healthcare provision. So I think it is important for us to legally protect and recognize our specific competences and unique role that have been evolving, of course, but I think this is also important in the future. I just want to have this last second to share with you all the website for our national association that we are running just today after this seminar for the first time, and has some information in Portuguese so that you can share. We were about 100 here, now not done, but I think we will believe it is important for having your attention as well. Thanks.
Oh, well done, Milena.
Thank
I
you
don't
so much.
actually
Fantastic.
have too much to add. I think Kelly and Adrian and Milena have sort of covered most of it. I do think technology is going to continue to advance. I do think that's going to continue to make our jobs applicable, because I think in the whole genome sequencing is currently entering the clinical translation space. It is available in some places, and I think that will only increase as things continue. So I do think that genetic counselors' role in result interpretation, with marrying of looking at what the clinical features of those individuals are and translating into actually interpreting what that means for an individual and family, are going to continue to be important. I actually was going to mention a whole lot that's already been mentioned, so I'm not going to reiterate, but I do think that some of these conversations around eugenics are probably going to come around again. I'm just thinking about NIPT and how that is expanding, looking into single gene disorders. I think that it's a fantastic resource, and it's very important for certain families, but I do think that that is going to become a potential issue in the future as well. And I'm going to leave it there, seeing if I don't want to take everything away if Kalinka wants to mention anything else.
Thank you, Nakita. Kalinka, you're the last one.
I also don't have too much to say other than, I just hope that we can work together to also try and get buy-in from other individuals, people that are influential in the sense, not to do the work of genetic counselors and to try and necessarily get training for people who would do the work of genetic counselors, but to get people on board that that are able to assist with creating these platforms for us to be able to get jobs, to be able to create more training programs, things like that. So I think as time goes by and as we create more awareness about genetic counseling, like on these kind of platforms, we might get buy-in from the right kind of people. The people that we need, that need to assist us, because we can't do it. We can talk, but we don't have the capacities to create the jobs, to create the programs by ourselves. We need the right people. And so I hope that that is one of the things that the profession will sort of create through sort of the snowballing effects of what we're doing, and our voices that they travel to the right spaces, and that will open up more opportunity as we go along. Yeah.
Well, thank you so much. We've heard quite a number of things. We've discussed quite a number of topics within the field of genetic counseling, and of course, my sincere to all that we are for collaborating on this important webinar. Of course, this is the first of many more to come. I also want to thank all the people in the audience that were patient listening to these important discussions. Of course, if you have any questions, you could email us but this will be made available, of course, on YouTube channel. And of course, these slides will be provided to you through our administration offices. So with that, I just want to say thank you so much for tuning in and see you next time. Have a nice day, everyone. Bye-bye.
Thank you very much to all. Bye-bye.
Bye. Thanks.